Hello everyone, welcome to Twilight. Problem is possibility, and this is Dr. Rajalakshmi. I am here today to go ahead with the second part of the tropical diseases, that is malaria fever. In last session, I have discussed about dengue fever, and in today's session, we are going to discuss detailed about malaria, and one of the most common tropical disease that we encounter, especially in the Indian setup. And we all know that it will spread by the mosquitoes and female Anopheles mosquitoes, and the parasite that causes malaria is Plasmodium. There are many species which can cause malaria fever. Among them, most common is falciparum, followed by vivax, ovale, malariae, and knowlesi. Knowlesi is basically zoonotic disease. We commonly see this species in the monkeys. The monkey to human transmission is a bit rare, but that is very well documented in other countries, especially in the Africa. We'll look at life cycle of the malarial parasite briefly. As I told you, this parasite enters human body through a female Anopheles mosquito. This mosquito injects sporozoids into the skin. From the skin, sporozoids will enter into the bloodstream, and it will reach the liver cells. Once this parasite infects the liver cells, these sporozoids will convert into schizones through a series of the steps. These schizones will get ruptured and it will get matured and rupture into the circulation and release the merozoids. All these merozoids will infect the RBC. In the RBC, it will pass through a series of stages: ring stage, trophozoites, and schizone. These schizones will rupture and release the parasites into the circulation. Repeated cycles will cause severe illness, and a few of ring forms will form gametocytes, will convert into gametocytes, and will further these gametocytes will enter into the mosquito and helps in propagation of the parasite from human to human through the mosquito. So repeated cycles in the RBC will cause severe illness and the fever. Because it has to pass through so many stages, the illness in the malaria will be intermittent. The fever will be three-stage fever. First, there will be 1 to 2 hours of the shivering, followed by the fever spike. Very high-grade fever, 103 or 104 also can happen. And these fever spike will last for 4 to 6 hours, followed by defervescence phase. The fever will come down and the body temperature will come back to baseline. So the fever will happen in the 3 stages. Most of the times that will be intermittent. Sometimes it can be daily fever. Sometimes it can happen at the interval of 48 hours or at the interval of 72 hours, depending upon the species or depending upon the load of the parasite. Other associated features: myalgia, jaundice. Jaundice is because of the hemolysis, intravascular hemolysis. Results in indirect hyperbilirubinemia. And in case of severe hemolysis, anemia will also we can see. So anemia, jaundice associated with fever and severe myalgia. Sometimes thrombocytopenia will also be there. These are the clinching clinical factors and few laboratory parameters to diagnose malaria. How do we diagnose? We'll diagnose with the help of light microscopy or rapid diagnostic test. With wide availability of rapid diagnostic test, and it requires very less skill, so these are preferred and over the light microscopy, because light microscopy requires some expertise and the skill. But coming to rapid diagnostic test, these can be species antigen or enzyme species specific enzyme, or sometimes pan species specific enzymes are also available. Once malaria is suspected, depending upon the clinical features and initial laboratory test, we need to go ahead with rapid diagnostic test or light microscopy. If you are doing light microscopy, if it is negative, if you are not able to see a parasite in the first smear, we have to do a series of the smears, 6 to 12 hours. At the interval of 6 to 12 hours, we have to do series of the smears, especially the uh, 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 especially in case of high suspicion and endemic areas. Or if light microscopy is negative, we can go ahead with rapid diagnostic test. If both are negative, series of smears and rapid diagnostic test negative, then we can confirm it as a negative for malaria. Malaria will be unlikely. So first, whenever malaria is suspected, we can go ahead with either light microscopy or rapid diagnostic test. If you are going ahead with light microscopy, if first smear is negative, you have to do series of the smears at the interval of 6 to 12 hours. If that is also negative, then we can rule out malaria completely. If initial smear of light microscopy is negative, then we can go ahead with the rapid diagnostic test. If that is also negative, then we can rule out malaria. So microscopy is Giemsa staining or oil immersion microscopy. It's highly sensitive, specific. The advantage of microscopy is we can know the species of the parasite, and at the same time we can know the burden of the parasite. We can know the load of the parasite. Quantification for it helps us to quantify the parasite load also. A skilled microscopist can detect asexual parasites at the density of less than 10 per microliter of the blood. But under typical field condition, most of the time the sensitivity is approximated 100 parasites per microliters. We can detect up to 10, but most of the times we can detect up to 100 parasites per microliter. And the cost is very less. We can see the response to the treatment. After the initiation of the treatment, we can repeat the smear. If parasite load is coming down, then we can say the patient is responding to treatment. If it is not coming down, then we may have to change our regimen. That parasite can be resistant to your treatment, and we can diagnose other conditions which can cause fever or same signs and symptoms. Coming to rapid diagnostic test, that can be falciparum specific histidine rich protein, vivax specific LDH, and pan malarial antigens like pan LDH or Aldolis. These are four different types of the kits available. Few are pan malarial antigens, few are species specific. For vivax LDH and for falciparum histidine rich protein. PCR and looped isothermal amplification techniques. These are mainly for epidemiological purpose, highly sensitive to detect mixed infections, in particular low parasite densities that are not detected by conventional microscopy or with RTT, rapid diagnostic test. But it's not readily available. Mostly it is for to detect drug resistance and for other epidemiological purpose. So once we diagnose the malaria, we need to start the treatment as fast as possible and as early as possible. What are our targets? What are our therapeutic objectives? One is cure. We need to eliminate parasite completely from the body, and we need to prevent the spread of the parasite to other humans. We need to curb man to man or human to human transmission and avoid emergence of the resistance. That is the reason we start with combination therapy, and we need to be very stringent about the dosing. Combination therapy will be artemisinin or with other derivatives. Uh, Artemisinin is acts rapidly, so it will decrease the parasite load immediately, and it helps to decrease the symptoms and signs very fastly. And it active against sexual stage of the gametocytes, so that will prevent the spread, human to human spread. The second drug will have slow onset and long term effect. This helps to avoid resistance and to attain cure and post-treatment prophylaxis. So we have to give artemisinin with some other drug in combination. Artemisinin is mainly for to decrease the load of the parasite and to prevent human to human transmission. The second drug is for long-term effect to complete cure and completely remove the parasite from the blood, and for post-treatment prophylaxis and to prevent the resistance. What are the regimens available? Artemether plus lumefantrine, artesunate plus amodiaquine, artesunate plus mefloquine, dihydromycin plus piperacquine, artesunate plus sulfadoxine, pyrimethamine. These are all 5 drug combinations that has been approved by the WHO. And these options are recommended for adults, children, including infants, lactating women, and pregnant women in second and third trimester. In the first trimester pregnancy, we should go ahead with the chloroquine or chloroquine plus clindamycin, not these drugs. Few general points about these combinations. Dihydromycin piperacquine is recommended for general use and it has long half-life compared to artemether lumefantrine, and the incidence of recurrence is less compared to artemether and lumefantrine with dihydromycin and piperacquine. Dihydromycin piperacquine plus artesunate mefloquine. These two have similar half-lives and similar frequency of recurrence. Dihydromycin piperacquine, artesunate mefloquine, artemether lumefantrine. These three combinations have been associated with prolonged QT interval. So, if patient is having congenital QT prolongation or high risk for VT or VF, better to avoid these combinations. Coming to artemether lumefantrine, so all these artemisinin combination therapies we have to give for 3 days. The dose of artemether and lumefantrine is 80 mg of artemether, lumefantrine of 480 mg if weight is more than 35 kg. Whenever we have to look at other coexisting drugs, because drug interactions will increase the exposure or decrease the exposure. Mefloquine, rifampicin, and efavirenz, and in smokers, the concentration will be less. The concentration of the lumefantrine will be less. Increased concentration of the lumefantrine will happen with in HIV patients who are on lopinavir or lopinavir ritonavir combinations. But there is no increase in the toxicity. We don't have to adjust the dose. And this lumefantrine, the absorption of lumefantrine will increase by co-administration of the fat. So we have to instruct to the patient, he or she has to take the tablet only with high fat diet. Better to take with high fat containing diet like eggs and milk, especially on the second and third day to increase uh, bioavailability of the drug and for rapid cure and to prevent emergence of the resistance. The second combination, artesunate amodiaquine. The dose is 200 mg of artesunate, amodiaquine of 540 mg. So it has the side effect of this combination is neutropenia. So particularly in patients with HIV and in those with zidovudine and cotrimoxazole, it's better to monitor for neutrophil count. It will exaggerate neutropenia. Concomitant use of efavirenz will increase the exposure of amodiaquine and will cause hepatotoxicity. So especially in case of HIV, we need to always look for interactions between antiretroviral therapy and artemisinin combination therapy. Artesunate mefloquine. The dose will be 200 mg of artesunate. Mefloquine is 440 mg. Mefloquine has been associated with increased incidence of nausea, vomiting, dizziness, and dysphoria, sleep disturbances. So you better to divide the dose, split the dose over 3 days. Rifampicin will decrease the exposure of mefloquine, potentially decrease its efficacy. Should followed up carefully to identify the treatment failures. Other combination, artesunate, sulfadoxine, pyrimethamine, weight-based regimen. If a patient is more than 50 kg, 200 mg of artesunate, sulfadoxine, pyrimethamine, 1500 mg, and pyrimethamine will be 75 mg. Higher doses of folic acid. significantly reduce the efficacy and should not be given concomitantly or with this combination. Dihydromycin piperacin, it has a weight-based regimen, 36 to 60, 120 mg of dihydromycin and 960 mg of piperacin, 60 to 80 mg, 160 mg of dihydromycin and 1280 mg of piperacin, more than 80 kg, 200 mg of dihydromycin and 1600 mg of piperacin. High fat meal should be avoided with this combination because this will significantly significantly accelerate the absorption of piperacin, and it will increase erythrogenicity and delayed ventricular repolarization. So you should avoid whenever there is congenital QT prolongation or another cardiac patients with high incidence of VT and VF. Dihydromycin exposure is lower in the pregnant woman. Piperacin is eliminated more rapidly by the pregnant woman, shortening the post-treatment prophylaxis. Piperacin prolongs the QT interval, but that prolongation of QT interval equal to chloroquine less than to quinine. Contraindications, as I told you, congenital QT prolongation, and who have other medical conditions which can cause QT prolongation and high incidence of arrhythmia. Treatment failure. Lack of resolution of symptoms and lack of resolution of parasitemia and recurrence of symptoms within 4 weeks of the treatment. Within 4 weeks, if patient again presents to you with the same symptoms and blood smear is positive for parasites, we need to consider it as treatment failure. So we can diagnose with the help of microscopy or LDH based RDTs, rapid diagnostic test, because Plasmodium falciparum is still rich for PF-HRP2 based rapid diagnostic test remain positive even if a patient is responding to your treatment, positive for weeks after the initial infection even without recrudescence. So if you suspect treatment failure or recurrence of the infection, avoid PF-HRP2 kit, and you should be able to diagnose with the help of microscopy or LDH based kits. The treatment will be artesunate or quinine plus tetracycline or doxycycline or clindamycin. If you observe, we have to avoid a second combination drug. We have to replace that second combination drug with tetracycline or doxycycline or clindamycin. Artesunate with tetracycline or doxycycline or clindamycin, or quinine with tetracycline, doxycycline or clindamycin, and the total duration is not 3 days, it is 7 days. Mostly the parasite is resistant to your previous regimen, so you need to change your regimen. Replace the second drug with doxycycline or tetracycline or clindamycin. If you encounter recurrence of the infection and recurrence of parasitemia after 4 weeks of the treatment, it can be because of recrudescence or new infection. But you cannot differentiate these two entities with the help of your regular microscopy or rapid diagnostic test. To differentiate recrudescence from the new infection, you should do PCR. But PCR is not available and not widely available. So every recurrence of the fever after 4 weeks, we should treat it as new infection. So you have to give first line ACT, and you can reuse if you reuse mefloquine within 60 days of the first treatment, it will associate with neuropsychiatric reaction. So we have to consider alternative ACT. So in the first regimen, if you give mefloquine, avoid mefloquine containing regimen. You can use artemisinin combination therapy in case of recurrence of the symptoms after 4 weeks of the therapy. But sometimes, especially in the endemic area, uh, we can see. So sometimes, especially in the endemic area, in case of the delayed presentations, we can miss treatment failure. Sometimes we can treat treatment failures as recurrence of the infection or new infection. So instead of first line ACT, whoever presents to you with second episode of the fever or second episode of the parasitemia, we have to go ahead with artemisinin with doxycycline or artemisinin with clindamycin or tetracycline instead of artemisinin combination therapy, especially in Indian setup or other endemic zones. So what is the role of primaquine in falciparum malaria? Primaquine generally we use to prevent recrudescence in case of the vivax or bowel infection. But in case of the falciparum infection also, we can use single dose of 0.25 mg per kg body weight along with artemisinin combination therapy to reduce infectivity of the gametocytes to the mosquito. To prevent human to humans spread, we can give single dose of primaquine. It doesn't need G6PD testing. We don't have to rule out G6PD deficiency. But this primaquine is contraindicated in pregnant women, infants of less than 6 months, and breastfeeding women with two infants aged less than 6 months. Special groups. In case of the obesity, you have to calculate dose as per ideal body weight, not as per actual body weight. In first trimester, we have to treat with the 7 days therapy of quinine and clindamycin or oral artesunate plus clindamycin. In case of HIV, avoid artesunate plus sulfadoxine pyrimethamine combination if they are already being treated with the cotrimoxazole, and avoid artesunate plus amodiaquine if they are being treated by efavirenz or zerovirin. What is uncomplicated parasitemia? No signs of the severity with more than 4% of the parasitemia. But even without symptoms, there is this group of the patients are high likely to have severe malaria and other malaria related complications like cerebral malaria and all. And this is the so this group of the patients are source for anti-malarial drug resistance because of improper treatment. One should diagnose such kind of the condition, should start artemisinin combination therapy as early as possible, and we should such patients requires very much close monitoring for the development of severe malaria. In case of the low transmission setting, mortality begins to increase when parasite density exceeds 2%, that is 1 lakh per microliter. Hyperparasitemia means more than 4% with no signs of severity. In case of the vivax and other two species of whale form hypnozoids. These hypnozoids will dormant stages of the parasite that will stay in the liver, and they can cause relapse of the symptoms, relapse of the disease after weeks to years of primary infection. Vivax can invade reticulocytes and can cause repeated illness and chronic anemia. Knowledge is a zoonotic disease, and they actually stays in the monkeys. Monkeys to human spread is very rare, but that has been well documented. It has a daily asexual cycle, so results in rapid replication and high parasitemia. If at all, if human spread happens, the disease severity will be very high. In areas with chloroquine susceptible infections, treat adults and children with uncomplicated Plasmodium vivax, ovale, malaria, and Noresi infections, either ACT or chloroquine. If in case of chloroquine resistance, you have to go ahead with ACT, except in pregnant women of first trimester. Primaquine has a very much important role in while treating vivax and ovale infections to avoid to avoid relapse of the fever. The total course is 14 days course, and contraindications: pregnant women, infants less than 6 months, breastfeeding women who are feeding infants of less than 6 months, and patients people with G6PD deficiency. G6PD deficiency, we can grade it as my normal, intermediate, and severe. Normal is more than 80% of the normal. Intermediate will be 30 to 80%, less than 30% will be severe deficiency. If it is severe, we should completely avoid primaquine. If it is moderate deficiency, we can give low dose uh, PRIMAQUINE, that is 0.75 mg per kg body weight once in a week for 8 weeks with close monitoring of hemolysis. The actual dose is, if G6PD levels are normal, the actual dose 0.25 to 0.5 mg per kg body weight per day, and the total duration 14 days, 2 weeks therapy in case of Vivax and Ovel. So every patient, after 3 days of artemisinin combination therapy or after 7 days of artemisinin or proper anti-malarial therapy, should discharge patient with PRIMAQUINE for 2 weeks of the therapy and ask them to look for hemolysis and ask them to repeat their LFT and CBP. Pregnancy or breastfeeding, consider weekly chemoprophylaxis with chloroquine until delivery, and once breastfeeding is completed, we can assess the G6PD status. Then we can start the PRIMAQUINE. Because PRIMAQUINE is contraindicated in case of the pregnancy and breastfeeding, they should receive post-treatment prophylaxis weekly chloroquine dose. Severe malaria. What is severe malaria? GCS of less than 11 and generalized weakness. Patient will be unable to walk, unable to get up from the bed, will feel very weak. And seizure episodes, epilepsy, more than 2 episodes within 24 hours. Acidotic, base deficit of more than -8 and bicarb of less than 15, venous plasma lactate of more than 5 millimoles. Severe malarial anemia, hemoglobin of less than 7 grams per deciliter or less than 20%. Parasite count of more than 10,000 per microliter. So hemoglobin low hemoglobin of less than 7 grams associated with parasite count of more than 10,000 microliters, and increased creatinine more than 3 milligrams per deciliter and increased blood urea. Jaundice, serum bilirubin of more than 3 and with parasite count of more than 1 lakh. Pulmonary edema, significant bleeding, melena or upper GI bleed will be there, lower GI bleed will be there. Sometimes epistaxis will be there because of very thrombocytopenia or other coagulopathy. Patient can have shock with normal blood pressure with high lactate and increased capillary refilling time, that is called compensated shock. It can be decompensated shock, very much hypoperfusion with the blood pressure of less than 80 and organ dysfunction. What is hyperparasitemia? Plasmodium falciparum parasite more than 10% itself. If patient is having plasma parasite load of more than 10% without any other signs, we can label it as cerebral malaria. Sorry, we can label it as severe malaria. And all severe malarial infection, we should always rule out secondary bacterial infection because these two high likely to coexist. So better to start an empirical antibiotic therapy in case of severe malaria. What is cerebral malaria? In case of malaria, malarial patient can present to you with altered sensorium. So that can be because of the cerebral malaria. But before considering it as cerebral malaria, we should always rule out the metabolic encephalopathy, metabolic causes of altered sensorium like hypoglycemia, hyponatremia, other dyselectrolytemia, increased urea and creatinine, uremic encephalopathy, and shock. So you should always rule out all these metabolic causes and secondary bacterial meningitis before labeling it as cerebral malaria. Cerebral malaria has been associated with increased mortality by 20%, and the pathophysiology behind cerebral malaria is cytoadherence. The parasite will adhere to the endothelial cells of microcirculation and will cause microcircular dysfunction in the brain. Rosetting and agglutination. Rosetting is binding of non-parasitized RBC to parasitized RBC. Agglutination is binding of parasitized RBC with each other. So these clots or rosetting and agglutination will further block the microcapillaries and microcirculation in the brain. Hemolytic anemia itself can cause cerebral dysfunction. You should always rule out metabolic causes and secondary bacterial meningitis. And the treatment will be artemisinin combination therapy and supportive therapy. Should always support his airway and control the seizure with the help of midazolam or phenobarbital or peraldehyde. All neuroprotective measures, like any other CNS patient, we have to manage, and better to start empirical antibiotics to cover secondary bacterial infection. Prognosis will be there is a chance of recovery. Sometimes within 48 hours, patient can wake up and will be able to extubate. But there are many long-term sequelae. Can cause permanent residual motor weakness. Long-term seizure can happen. Memory disturbances, cognitive disturbances, behavioral changes, and some patients will land up with vegetative state. What is black water fever? Black water fever is nothing but because of high parasite load, there will be severe intravascular hemolysis, rapid drop of the hemoglobin. This results in cola colored urine, very black colored urine because of hemoglobinuria. Not only the infection, sometimes the treatment, amino alcohol drugs, quinine, mefloquine, halofactory. These drugs will further exacerbate oxidative radical mediated hemolysis. Other drugs, artemisinin, chloroquine, piperacquine, can cause oxidative hemolysis, but the incidence of a drug associated with the black water fever is a bit less, very rare, but it has been documented. So this is the end. In case of the black water fever, we need to try to look for the drug which is causing hemolysis and try to change your regimen. Sometimes patient can land up with acute kidney injury and dialysis. We need to manage the kidney part. Thank you, and we'll meet up soon with the third part of the tropical disease, that is leptospirosis and scrub typhus. Stay tuned.